Good afternoon, everyone, and welcome to this afternoon's webinar on the Royal College of Psychiatrists Digital and Data Literacy Framework. My name is Faith Ndebele, and I'm going to be chairing this webinar this afternoon. We are so fortunate to have three fantastic speakers who will help us to discover more about this new framework, which aims to prepare psychiatrists for working in healthcare in the digital age, post the COVID-19 pandemic. You'll hear more about providing psychiatrists with digital leadership skills to navigate the multiple levels in healthcare systems in order to improve patient outcomes and experience, increase clinician efficiency and patient safety, as well as enabling digital mental health services for patients. There's recognition that psychiatrists need to have a core level of knowledge and skills in digital literacy. And we accept that not everyone will be an expert at this. Hence the framework and our webinar this afternoon, which is an introduction to this subject. I will take you through what we're going to be doing today, but first of all, we're going to look at some housekeeping details. Following our third speaker, we will have a joint Q&A with all of the speakers at the end of the webinar. Please feel free to tweet throughout the event using the hashtags at RCPsych and at RCPsych Live. This webinar is being recorded and the recording will be available to watch afterwards. Where speakers have given us permission, slides will be uploaded to the online resource gallery after the webinar for your review. And I know that there's always a question about certificates for evidence of CPD. These will be sent out within a week following the webinar. All right, so I'm not going to say much today because I think we should really give this hour over to our three speakers who have all worked really hard over the last few years to come up with this framework. And so we are going to start off.
Faith, you've muted yourself.
Looks like I muted myself and I'm not sure how I did that. I was just about to say that we are starting off the day with Dr. Subodh Dave. Subodh was elected as Dean in 2021, and he holds this role until 2026. He has overall responsibility for setting standards for and facilitating the effective delivery of psychiatric education and training. He's an international medical graduate, moving to the UK in 1995 and obtaining a CCT in general adult psychiatry with endorsement in liaison psychiatry. He currently works as consultant liaison psychiatrist in Derbyshire Healthcare Foundation Trust and is professor of psychiatry at the University of Bolton. He is also the deputy director of undergraduate medical education, and in that role has led innovations in introducing and embedding simulation and lived experience involvement in the training of medical students at the University of Nottingham. He has held training roles at all levels, spanning undergraduate, foundation, postgraduate training, both in the UK and internationally, and is passionate about ensuring that training, assessment structures, and CPD programs lead to improvement in patient care and clinical outcomes. He is thus the perfect person to speak to us about why digital literacy is a critical skill for trainees and for the workforce. Subodh?
Thank you so much, Faith, for that kind introduction and rather long introduction. I feel a bit embarrassed, but thank you so much. I really appreciate that. So I don't have any slides. I think some people have questioned whether there are any slides, and I don't. I really want this to be a conversation, so and an interactive chat. So I can see many people in the room whom I know. So thank you first of all for coming to this important session. So my first question are there any digital skeptics in the room? You know, people who are worried about or feel a bit like my title is that this is a critical skill, but who feel that, well, it's definitely not a critical skill. I'd like to hear from them. But one of the things that happens in seminars like this is that we attract all the people who are, very, very digital, pro-digital innovation. And I think it's hard to really engage with people who are not on the same page. And I feel that's part of the problem, certainly, that I feel, that we attract diehard supporters, but engaging with people who are not really convinced of or skeptical or self-styled digital dinosaurs, how do we involve them and engage them? And I think, so for me, I think when I put digital literacy as a key priority for my manifesto, that was 2 years ago when I stood for Dean, it wasn't to paint a kind of a picture of, let's just make sure that digital innovation, we are part of that big trend of digital innovation, and then we go forward and embed digital literacy in everything that we do. It was really to kind of make sure that we don't lose the opportunity of making outcomes better for our patients, and we use every help that we can get from technology and digital advancement that we can. I don't know how many of you have heard of ChatGPT or used ChatGPT. It's been a lot in the news in terms of AI. I just want to set the scene. And as a part of this talk, I asked ChatGPT to write my talk for me. And, you can do this kind of things with AI now. And obviously, it was not that good at writing this particular talk. It was pretty good, however. I asked also, I'm here at the APA attending a meeting, the American Psychiatrists Association meeting in San Francisco. And I met up with a friend who's quite interested in ChatGPT and AI. And we asked AI to write the strategy for elective recovery. Elective recovery is about how do you manage waiting lists in the NHS. And believe you me, in about 4 seconds, it came up with all the key points that you'd want digital, you want in a strategy document for managing waiting lists. So things like prioritization and triaging, things like capacity management, things like training the workforce, clinical leadership, etc. And it came up in a very categorical fashion in detail. Now you can see that how that would help people who write these strategy documents. And I feel that for me, all of this is the opportunity cost. I think in the pandemic, we suddenly had this explosion of digital communications. We saw MS Teams coming up in a big way. We saw people finally doing interviews online. And New York Times ran a headline saying that 10 years of digital advancement happens in 2 weeks in the NHS. Now, to be honest, NHS was doing all of this in the Shetland Islands, which is way up north in Scotland. I used to go and teach there. And this was in 2005, 2006, I was teaching up in the Shetland Islands. And each time I would go, I would be based on the main island, and then other nurses and the healthcare workers and the doctors, GPs, etc., were based on the 10 islands across the Shetlands. And it was all set up for those, it's now the world has kind of become familiar with Zoom and video communications and Teams. This was all set up. And I feel that, the fact that we failed to use that, it was something that I personally experienced, because, when I became associate dean at the college, it meant coming to London. This was obviously in the pre Zoom era. So it meant coming to London for meetings, which meant that I was trying to adjust trying to balance my clinical work with all the other work I was doing. I tried to set up telephone clinics, and it just was not possible for me to set up telephone clinics. My system wasn't designed to allow telephone clinics or Skype clinics to happen. Ultimately, I did it, but I had to use my secretary's goodwill to make that happen. And the reason why I tell you those story is that it takes 10 to 20 years for any kind of change to filter down to the ground level. Now, if we are really keen on making change happen, if we're really keen on helping our patients, then we want to use every possible lever that we can. How can we use every possible tool that we have at our hand to improve outcomes for our patients? And I feel that we really risk there's a real risk that we will just not be ready to do that unless we embed digital literacy as a critical skill for the entire workforce. On average, every NHS organization, whether you're in a trust or on a healthcare board, we are uploading something like 25,000 pieces of data every day upstream to NHS Digital, NHS Benchmarking, CQC, various bodies. How many of those 25,000 pieces of data do you get back to help you in your clinical work? Does anybody get a list? I mean, I have asked this question in the past because I worked with this. You know, I used to be a community psychiatrist. I'm a liaison psychiatrist now. As a community psychiatrist, I would have liked my system to tell me that, Subodh, you've got these 350 patients on your caseload. Of that, 75 are people who meet the criteria for treatment-resistant schizophrenia because they've been diagnosed with schizophrenia. They've been offered 2 antipsychotics for more than 6 weeks. And of those 75, you offer clozapine to about 20, but you haven't offered the 55. Now, I make that example up? No, I don't, because we've done POM audits across the UK, and we know that there is a huge variation in the number of people identified with resistant schizophrenia and in the number of people who are actually offered clozapine. And we know from a NICE guidance and from all the academic evidence that clozapine would transform care for at least some of those people. In fact, we would save billions in reduced inpatient costs if we were to actually optimize the prescription of clozapine to the people who most needed it. Data could help. Digital technology could help. And where is the barrier? I feel the barrier is in us. It's in us as clinicians not asking, what is all this 25,000 pieces of data? Are they just for compliance? Or are they for improvement? And I feel unless we get into that space, things are not going to change. Last year alone, more than 60 billion pounds was invested in digital tech. 60 billion pounds. Of that, about 7 billion pounds was in mental health tech. You all must know this, right? That your patients, perhaps you yourselves, are using health apps on your smartphones. Pretty much most of my patients are using them. Now, can you imagine a scenario where a drug is developed, new drug is developed, and clinicians are not involved in the drug development at all? But that's exactly what's happened with a lot of these apps. And so for me, I think this whole conversation today is a little bit more fundamental. I don't know how many of you here are psychotherapists, but I feel that we haven't really questioned, as clinical psychiatrists, as clinical scientists, what is this whole online world doing to the fundamental, concept in psychiatry about attachment. Now, I don't know how many of you read, there's a series of essays in the New York Times called Modern Love. I think it was kind of, touching upon things like online relationships, like, people are mostly finding relationships on places like Tinder and Bumble and stuff like that. But it's also then being New York Times essay goes into great detail around what does attachment mean in this modern world? What does love mean in the modern world? And for us as clinical psychiatrists who are really engaged in the whole idea of formulation, understanding psychobiosocial and how it applies to our individual patients, personalizing the care that we provide to our patients, I feel that restricting the thought of that whole online development to online harm or gaming, I think is a very narrow perspective. So for me, today is really about broadening our horizons, engaging with the art of the possible, engaging in how can we harness this technology to make our patients' lives better. And as I hope that all of you have seen our new curricula, but our new curricula essentially have two big lenses. So the first lens is around person-centered care. Well, how do we personalize the care that we provide to our patients? How do we apply population-based evidence that usually comes across in NICE guidelines to the individual patient in front of us? How do we make it, like a precision psychiatry, precision medicine, like personalize it to them and to that individual context? The second big thing is around communities, and how do we, that's public mental health. How do we see ourselves not just being responsible for the care of our individual patient, but also for the communities? How do we make sure that as clinicians, we are improving the outcomes of our entire population? And I feel that digital technology can help in a big way. Of course, there are lots of barriers and there are risks, and I want us all to be involved in the process, just like we would be involved in the process of drug development. I really worry that we will not have a pipeline for the changes that are coming. And some of them might be existential, even, I think for us as medics, for us as psychiatrists, for us as scientists. And I think we really need to kind of have that digital ready pipeline. Faith, in your introduction, you introduced me as responsible for education and training. And I think in most people's minds, that is my role. I think the second part is sometimes not mentioned, but the workforce is also an important part of my role. So I think for me, it's training and workforce. how do we make sure the workforce is ready to deliver the best quality care for our patients is what I see as my role. And I want you all to judge me and my efforts and my team's efforts on that count. And I feel that I'd be failing my duty if we don't really invest in preparing our workforce, so that our workforce is at least at base level ready, but also that we have a pipeline of our future scientists and future practitioners in this area. So my ask for you all before I finish is going to be this. So how do you think you will involve, I'm assuming that a lot of you here are digital, natives or digitally literate already or interested in the whole field. How will you involve those who are not there, not are skeptical? How will you engage them and involve them? And then secondly, what is your contribution? How will you join with all the efforts in the college? And what can you do? How would you like to be involved for us to translate this vision so that we can actually harness our digital literacy skills to make the lives of our patients better? So I'm going to stop there. I want to thank all of you, but I want to especially thank Eloise and other staff members for organizing the webinar so efficiently. And thanks to Asif and Ross, whom you're going to hear from, and Faith. But a final reminder that we can't just rely on the Faiths and the Asifs and the Rosses of this world to take this forward. We have to take everyone else along with us. It has to be mainstreamed. And that is why my plea that, well, let us make this as a critical skill for all of us, for our training and for our workforce. Thank you. I think you're still on mute, Faith.
Subodh, thank you very much for that talk. And just to remind everyone to please put your questions in the question and answer tab at the bottom of the screen. Okay, so introducing our second speaker today. Absolutely delighted to welcome Dr. Ross Runciman this afternoon, one of the lead authors of the Data and Literacy Competencies for Psychiatrists, which was launched in March 2023. Ross works as a general adult psychiatrist, consultant psychiatrist at Wootton Lawn Hospital in Gloucestershire Health and Care NHS Foundation Trust. He is the medical lead for quality improvement, as well as leadership and quality champion for Gloucestershire Health and Care NHS Foundation Trust. And he was in 2019-2020, the Psychiatric Trainees Committee Chair, involved as a trainee in developing the new 2022 curricula. Ross was in the first cohort of the college's Leadership and Management Fellows Scheme, and now is an associate program director of the LMFS. Ross is the lead co-author, as I've said, of the competencies launched earlier this year. And really happy to hear from you, Ross, on the data and digital literacy standards. Thank you.
Thanks so much, Faith. Really appreciate the very generous introduction. So hopefully you can see my slides. I'm afraid I'm going to be a little bit more structured, as you'd expect, with standards following such eloquent and interesting and stimulating introductions. Thank you very much. So why do we need some standards? Where are we with this? And why do we need a framework in the first place? So I had to go and Google Luddite, didn't I? And I think it's a really interesting word. I'm fascinated by the word Luddite because it's used now, I think, quite colloquially as an insult. As someone who would reject something that could be progressive, that could be good for people. And yet I'm really struck by the word Luddite and the movement. And as we can see in this picture here of someone actually showing leadership and thinking about what happened. And these were people several hundred years ago who felt threatened, who felt that their key skills would be, or craft would be taken away from them, that they would be replaced by machines. And I feel like I'm starting an episode of BBC Radio 4's The Long View, so I apologize. It's one of my guilty pleasures, shall I say, that I enjoy The Long View, where they look back at history and how it's repeated. But here we have this point in time with our kind Dean exploring and reflecting about how ChatGPT and other forms of AI could replace, surpass us, but also possibly complement. And I wonder if in this response, the extent to which we're scared, the extent to which we have fear for this, because I get scared when I think about some of this new technology. Now, as Subodh said at the start, a lot of us joining this webinar almost by definition are going to be people that look forward, perhaps, or at least are very open skeptics. And I'm really curious about the people that aren't here, and how do we include them in this conversation, and how do they have a way, and how do we support them in a way to move forward. So if I just move us forward, where are we at the moment? Now, this is a very rudimentary summary of some aspects of digital strategies for the 4 nations in the UK. And I was looking at this last night again. I was thinking, oh, I bet this has changed. So these are a few snapshots of why digital is important, from delivering healthcare to patient experience to getting efficiencies, all of those kind of boring but important terms in terms of driving forward ultimately the best patient care. But there's a risk in these strategies that it feels like it's a kind of management speak that gets us to that destination. And again, I think our job, as is in many situations, to make manifest the benefits to all our colleagues, but also to our patients, and what we can do things better for them as a result of technology. One reflection, and not to be critiquing the GMC, but reflecting on their position, is it's really difficult to see their digital strategy with regards to doctors now and doctors of the future. And there's very little when you look at good medical practice, when you look at their generic professional capabilities, which I think is interesting. As Subodh said, the new curricula came in last summer, and we have this person-centered care focused. We have this sense of measuring our progress very carefully, of thinking about capabilities rather than competencies. But there's an opportunity for a digital framework in this. However, thinking beyond training, the idea with our framework, Asif and myself, as well as lots of colleagues, was to create something that was for all doctors working in mental health and not just those in training. Briefly thinking about what other colleagues have done, and what's surprising is it's difficult to find, and I don't want to be so definitive, but it's difficult to find what another medical Royal College has done with regards to a digital framework. If anyone on the webinar today has evidence of that, please share it. I want to learn. I want to reach out to those people and get some information from them so we can work together. But I can't find a digital framework from other medical Royal Colleges in terms of other doctors. However, other healthcare professions do have this, and I've put a QR code there to complement the hyperlink, and the slides can be shared as a PDF afterwards if you wanted to follow that link, which takes you to NHS England, HE, as was until very recently, and lists these different professions and their approach to digital literacy. And I took this wheel from one of those frameworks to just show where it touches on. And I think what's interesting, it's one of those frameworks where the themes can be drawn right across the professions. And again, I think that's really good in terms of how it unites us in our multidisciplinary working, but also thinks about those different domains. So I think that's grand. I also really like this wheel because at the center, as it should have, is person-centered digital literacy. And for me, that speaks not only to it being most importantly focused on our patients, but also focused on us as fellow human beings, and it not being about the big system and big data, but what does that mean for us? What does that mean for patient care? So there are some other examples to explore. Your thoughts on those would be really appreciated. So Asif has been a digital enthusiast for a number of years, and we'll tell you more about that. I'm newer to the game. I'm interested in these frameworks and in programs of learning, how we can have a way of really understanding this, but also having set expectations of what this is, because otherwise it can feel quite overwhelming. I feel overwhelmed sometimes about all this new stuff. How do I encounter and process this? So along comes Derek Tracy and lots of other really dedicated colleagues to come up with these 2 papers that came out earlier this year and one last year as well. And again, on the right, QR codes to take you to those papers. If you'd like a read, the hyperlink will be sent out in the slides. And they break down across 2 papers huge topics of digital literacy and think about the different ways in which these connect with mental health care, how it can benefit our patients, how it can benefit us. And I really recommend you to read these. Really useful resource material, and we unashamedly stole key pieces of this for our framework therein. But they're really useful material for everyone to read, and recommend them. So just going back to why there's a framework, we like digital. I'm sure you've heard that message already. Why are we bothering with a framework? Well, it's what I mentioned a bit earlier, is that, you know, we've got something that's new, we've got something that's really evolving, and there could be a temptation to kind of almost firefight, to kind of roll with it. But there does need to be a strategy for engaging with this and understanding. And alongside this will be ethics. And I was looking at the chat just as we were getting going, and some really powerful thoughts there around what are the ethics of big data? You know, how is this going to impact that patient and healthcare professional relationship, and what do we need to be mindful of? There's lots to navigate here. I think it's also recognizing, again, in a non-threatening way, and thinking to that refreshing look at Luddite and what that might mean and the feelings associated with that, of this is a skill that we want to evoke in all clinicians and support in all clinicians, and we've got leadership roles to achieve in order to deliver that. And it needs to not be just, well, the new psychiatrists are coming through, they're digital natives, so they'll sort that out. This is for everyone. You know, it might make our work easier. It might mean that we can do more of the things that we actually love, that we actually keep us going in the job. So this needs to be for everyone, and isn't just for trainees, and it's throughout healthcare organizations as well. So that latter point is that it's not just whatever stage of training or working you're at, but it's also thinking about if you have a role in integrated healthcare systems, for example, ICSs, or if you have a role as a CCIO, you know, or another clinical leadership role. That's really important in what you can influence in digital and in data. So what have we done? Well, you know, we've spent actually probably in total a couple of years, although much more intensively last year, coming up with this structure. Asif has been leading with the frameworks and the themes, which I've been really, really grateful for. It's lended clarity where I was just a bit noisy, I think, with my ideas. So we've got these 3 strong themes, and it's about saying, what are the deliverables that's going to come out of this in terms of engaging with digital, engaging with a framework to help us with this new technology. Obviously, clinician efficiency and safety of our patients is paramount. Again, the outcomes as well, and there's data sets that we can help attribute and understand with that, but obviously thinking about those qualitative aspects. And finally, it's that enabling aspect to digital mental health patients. So I was thinking in England, just for example, you know, that right to access all your GP records, suddenly letters available to everyone, but how progressive and convenient for patients that they can suddenly get to their records much more easily. You know, if you've got, for example, System 1 app on your phone, suddenly you've got that data there. So these are progressive ideas that are helpful. We need to engage with this and understand how they can affect what we do. As before, I mentioned those levels, and levels I think have never been more important in healthcare as we are now. We obviously need to think about what we can do as an individual, our role innately as psychiatrists within a local healthcare team, and the influence that it has on that team's performance on what we're doing, but also then thinking wider than that with the locality, and then of course at the trust or health board level, and finally at the system level, with much more emphasis being put on that. And I think that gives, again, if we've got this language of digital data, we can engage on that system level much more easily, as Asif will expound shortly. So in terms of our approach and where we are with the framework, and this webinar comes as a very interesting time, which I'll tell you shortly about, is that we did our task and finish group. We've gone through committees within college, and we've reached out to external bodies such as the Statutory Educational Board, formerly known as HEE, and and across the 4 nations to get views and perspectives. And now we're engaging on a virtual roadshow beginning today to really take this around and understand people's perspectives on the framework. As said, here's just a snapshot of the people that have been involved, and it's been really great to hear all this expertise and so forth to get where we are. Brief example is just focusing on the doctor as an agent of change, and I liked picking this example because I thought it was something that it sounds like it could be out of business speak, and that's certainly not the intention. But actually to think about this, to say, you know, we may have our skeptical thoughts, but actually here we come along, people will look to us, and if we give a perspective that we don't trust this new digital system, we don't trust this new approach to it, but an informed approach can make a real difference to our team, and how that might resonate across at the clinical team level, if we have opportunities or responsibilities beyond that through locality, and again how that would change if we were taking a CCIO level as well and into the system. But all doctors, as said, you know, we lead by example, and the expectations that is given to us, we need to show how we can lead on this and lead on digital going forward. So what do we do next? You know, obviously, I really want you to go and look at the framework, and I'll give a link at the end of the presentation to do the same. We've got a formal launch webinar. We've got a virtual roadshow coming. We want to provide some really useful digital materials to help with delivering this framework. So we're not just saying, here is another jump that you need to jump to, but actually providing some learning materials for that. There's work ongoing, not just within college, but without, to look at a digital fellowship and to think about what comes next to actually inspire future digital leaders in that way. We're collaborating with NHS benchmarking, and we're also thinking about in the longer term how this can be integrated into both training, but also into appraisal and the CSER route as well. Now, finally, as I said, fantastic timing. Tomorrow is the closing date for all Royal College Psychiatrists awards for this year. And so following this QR code or the hyperlink there will take you to the awards page. And one of the things that Asif has championed is the award for the best digital team. So if you've got some recommendations in mind, or indeed the other awards, please do follow that QR code and get your submissions in ASAP by the end of tomorrow. Now, I did mention the framework, that's why I'm here. And if you follow this QR link here, and again, the hyperlink is there, but if you go to the college website and put in a digital literacy framework, it will come up as well. But the feedback that we've been taking and receiving feedback through the website closes again tomorrow. So please do go onto that website. Please put your thoughts and questions in there. We want the hive mind on this. We need as much feedback and thoughts to make sure it's the best framework, but also to have a think about how we can then implement this, how we can make manifest the changes it discusses. So your thoughts, as always, are really, really important. And I'm going to pause it there and look forward to answering the questions at the end. Thank you.
Thank you very much, Ross, for that really insightful talk. And now for our final speaker, I am really pleased to introduce Dr. Asif Bachlani, a real champion of data and digital literacy. He works as consultant psychiatrist and clinical lead for the Autism Pathway at Priory Walking Hospital, and is also an associate and non-executive director for Kent and Medway NHS and Social Care Partnership Trust, with his portfolios being data and digital. Asif has held various managerial and digital positions in NHS and in the independent sector, and has co-authored various policy documents and papers around data and digital. He has an interest in clinical value of data and data literacy for clinicians. Asif set up the first ever data event for clinicians, initially regionally in 2018 and then nationally from 2019 via the College Better Data, Better Care series of conferences, which is now in its 4th year. And I'm delighted, Asif, to welcome you this afternoon for your talk. Thank you.
Thank you, Faith, for the kind introduction. And I always summarize my bio as a data nerd, and I hope I would share my love of data in the talk that I'm going to be doing today. And what we're trying to do with this talk is to talk about, well, we talk about data and we talk about high quality data or data admin on clinicians, but actually ultimately what we need the data for is to improve the quality of care that we provide to our patients. So we often have triangles in psychiatry. We have the Maslow triangle. Here's another triangle, which is the data, information, knowledge, and wisdom, DIKW. And what I'm going to try to do in our talk today is to move, hopefully very quickly, from data to wisdom and show how, in a concrete way, as a clinician, you can lead the process of service development or improving the care for patients using the data that we have available. So understandably, I think a lot of people feel this way. We often have to collect various pieces of data around our patients and healthcare, and sometimes it's not overtly clear about why we're collecting the data, or we even get feedback on that data. And obviously, Subodh talked about how many pieces of data that we send into the centre. I guess the more interesting question is, how much of that data is linked to clinical care and how much is it superfluous? And that's a conversation perhaps for later on. But if we get the right kind of data and data about our local populations and how our service is working, then actually you can do these things. And the example I'm going to use very briefly is about setting up a personality disorder pathway in Kingston in my previous organisation. So again, I think a lot of us know this, and I kindly stole this slide from Aisha, and obviously recognising her at the top. We know that a significant number of people who get help from the NHS have mental health problems, and it's approximately 23%. But we also know that mental health services are incredibly poorly funded. And so we have a treatment gap. And one way of trying to close that treatment gap is data to identify need and to ultimately hopefully demonstrate the value that mental health services provide to the wider NHS. And that's becoming increasingly important as we move into ICBs. So what's the problem that we all often face as clinicians? And what's the question that I think we often need to ask is, does our service meet the needs of our patients? You could go one further than that and say, does our service meet the needs of our local population or place? And if the answer is no, then I think we as clinicians are absolutely vital to meet the needs of our population. And I think ultimately have the responsibility to ensure that we do improve the quality of services that we provide. Because if we don't do it and we don't advocate for our mental health needs of our patients, I'm not sure who else is going to do that. So, as I mentioned, I'm going to be talking about Kingston, and we're going slightly back in time. And this is sort of 2017, 2018, and eventually up to 2019. Now, a lot of people don't like clusters, and I think I'm in the perhaps minority, maybe in numbers of 3 or 4 that actually quite like clusters. And for people who are not aware, clusters is a potential system of how you differentiate the needs of your population. It has been used for other things, and I think that's part of the problem around clustering. But for the purpose of today, what I'm trying to show you is the team that I used to work for, which is South Kingston CMHT, and our patient population. So the bars are the proportions of people in the various clusters, and 0 to 8 is mood, anxiety, and personality disorders, and 10 to 17 is psychosis. And for completeness, 18 to 21 is dementia. So obviously in a general adult CMHT, you're not expecting to see people with dementia in your service, and that's why there's no bars at 18, 19, 20 to 21. The other thing that's there is as a red line, and that was the trust average for all adult CMHTs. And what hopefully you can see is certain bars are above the line and certain bars are below. And one of the bars that are above is cluster 7, and cluster 7 is recurrent depressive and anxiety disorders. And for a lot of our patients, people who've got personality disorder traits, or perhaps not severe personality disorders, which would be classified as cluster 8. If we then look at our psychosis rates, you can see, generally speaking, although not completely, our rates of psychosis in our team are quite low and lower than the average within the trust, and our 7s and 8s are actually higher. And actually, if you add up the 7s and 8s together, you've got over 40% of our population have either personality disorder, severe personality disorder in cluster 8, or at least personality disorder traits. And so very quickly, when I started working for that team back in 2017, it soon became apparent that a significant proportion of the people in my clinic had personality disorder or strong personality disorder traits. And we really didn't provide the care that they needed. Often patients were asking for one-to-one DBT and one-to-one MBT. And for those who know NICE guidelines, you'll know that those are the kind of key psychological interventions as recommended by NICE. This is, however, what we did offer. And if you quickly scan the list, you'll only see one thing that's approved by NICE in regard to treatment for people with personality disorder, which is psychodynamic psychotherapy. Now, that's not to say that the other interventions don't have any evidence base, but if you're trying to stick to a high quality mark and look at NICE, then only psychodynamic psychotherapy was available. Now, that was individual and that's brilliant. But if I told you I had 300 patients on my caseload, and for the whole borough of Kingston, the therapy team could only treat 12 people in a year, that doesn't fit. And that doesn't fit the needs of our population. And some patients just don't want to do groups, and that's completely understandable. And so it became very quickly apparent that the services that we are providing for our patients don't meet our needs. We were fairly decent at managing psychosis, but given the fact that 40% of the caseload of South Kingston had a personality disorder, we really were not treating a very important diagnosis that our local population had. And you've already heard me say this, and obviously you would expect me to say true, that I absolutely do feel it's fundamental that clinicians lead the development of the services in their local areas, because we understand the needs of our population, and far better than, I would say, middle management who don't work necessarily in the place that we do. So we've got a problem. We've identified a problem. It's been known for many years. In fact, it's been known for 5 years that we were really struggling with people with personality disorder. How do we get from there is a problem to there can be a solution? And one way of doing that is data. And the other way of thinking about it and to make sure that we have a framework is looking at a pathway. So this is a fairly standard pathway of a patient coming in from primary care or GP referral into our system. And again, for the purpose of the talk, I'm going to be focusing on adult mental health, but it could be any pathway. And so we know that patients come in through a single point of access, and obviously as they get more unwell, if they can't be managed in the community, they go into the ward and potentially long-term rehab. So one needs to have a framework about how to analyze the data and how to make our story stick and make a difference. And one way is a pathway approach. And when we end up talking about pathways, we end up talking a lot about beds. And the reason we often talk about beds is that there often aren't enough beds in our system, and it's often very difficult to get people admitted into beds. And so the argument could be is if you have well-resourced community services as what the purpose of the CMHF is, then people hopefully won't go into a crisis and hopefully won't need to go into a bed. And that's not to say that going to a bed's anything wrong, but why wait for somebody to get into a crisis to get the help that they need? Why don't we treat them early in an early intervention type way? So as a clinician, that makes a lot of sense to me. I don't want my patients to deteriorate and to go into a ward. From a commissioner point of view, they are really keen that things are efficient. And so if you start talking about being treated early in the community, which is cheaper than being in a hospital bed, which roughly costs 150,000 per year for one bed, then that makes the commissioners happy. And so you have to change the language that you're using depending on the people that you're talking to. So let's start looking at the data. And I think we're really fortunate in England and in the UK to have one of the best kind of data sets available around mental health, NHS benchmarking data sets. And I'm just going to show you a few of the data sets. This is, again, old data, and this is a piece of work that I did for the South London Partnership in 2018. And as I said, as with any system, and whenever you talk about any mental health transformation, you always talk about beds. So this is all of the UK trusts. Green is London, and red is my old trust, which is South West London, St George's. And what you can see here is South West London has a relatively relatively low bed base. You then have cluster 8, which is personality disorders, and you can see there's a relatively high numbers of people with cluster 8 in our inpatient beds. And again, that's not necessarily a problem if you have lots of beds, but if you don't have lots of beds, that's a problem. And second of all, if we don't have the right treatments in our inpatient units, and in Tolworth Hospital, we didn't have psychological interventions or the OT kind of interventions that would be best practice for people with personality disorders. And then this is trust-wide data. And from this, you can see that Kingston, one of the few boroughs, the 5 boroughs that didn't have a personality disorder pathway or team, had one of the highest amounts of people in beds comparatively to the rest of the 5 boroughs of South West London, St George's. And then we look at community. And this is where I think it's absolutely vital that we as clinicians are actively engaged in the data sets, because sometimes the data can tell us the wrong things and we need to have that kind of clinical narrative. So top graph is community caseloads of clusters 1 to 8, which is the mood, anxiety and personality disorder. And you can see South West London has the 4th lowest amount of people with mood, anxiety and personality disorder, of which obviously personality disorders are there. But on the bottom graph, you can see that South West London has the 2nd highest amount of contacts. So you would say, notionally, looking at that data, then that means actually we're doing a really good job in Kingston and the rest of CMHTs and seeing people with mood, anxiety and personality disorders. But I also knew that we weren't providing the level of care that I know that we should have done. And I know that Kingston has the highest amount of people in beds with cluster 8, and so does the trust. So how does that make sense? It makes sense because I'm in the team and I know what's happening with our patients, and I know that we're not providing nice concordant care or therapeutic care, but we are seeing patients. Now that is nice in itself, but it's not therapeutic or meaningful for our patients. So although we've got high contacts, the quality of care or the value of the care is limited, and therefore we're not providing the care in the community and people end up in beds. And so we use this as a starter for 10 for our 18 months amount of work in order to get a new pathway commissioned, and we eventually got some money, and this is what the pathway looks like. And obviously that's a whistle-stop tour about how one goes from realizing there's a problem in your team or your service to thinking there's something we need to do about it, to a starting point, which I feel is data, taking a pathway approach to get to where we were with the Kingston Personality Disorder Pathway, which launched in July 2019. So in the next couple of minutes that we've got left in my talk, I just want to talk about sort of key enablers to make it happen. One is making sure we work in an MDT fashion. What I would say is, in my experience, if you want a significant cultural change within your team or significant change in the way that you deliver your services, it has to be MDT. We involved the whole pathway and made sure that everyone who would see a person with personality disorder was involved, and there is no I in team. And if you want a superficial change, then you don't need to worry about MDTs. But we didn't want that. We wanted real good quality care for our patients with personality disorders. I love this slide. I've stolen this from the QI team in South West London. We're psychiatrists. Our strengths and what we're supposed to be good at are relationships, and lo and behold, improvement in healthcare is 80% human. So what does that say? That the 80% of getting things changed is not necessarily technical skills, but it's relationships, and we're supposed to be the experts at relationships. So we're absolutely well placed to develop and improve the services in our local areas. I also wanted to mention Health Watch, which was the straw that broke the camel's back. And if we didn't have the support of our patients and carers, we would have never got a new service commissioned. And we shouldn't be afraid of having our patients and carers involved right from the get-go. We often do this poorly, and we didn't do it particularly well in Kingston either. But that get them involved right from the beginning to help shape the services that we're trying to provide in order to make sure we're absolutely meeting the needs of our local population. My pretty much last slide is just to talk about, if I've at all interested you in data, and I hope I have, and shown you the value of data, this is where you can start getting data from. And obviously these slides are going to be available afterwards, but you can get them from your trust, your borough, that's either from public health or the CCG. There are regional data sets, and then of course there are national data sets, of which I've spoken predominantly about the NHS benchmarking network, whose data I think is absolutely fantastic and incredibly insightful. But a good place if you're doing a starter for 10 is the Royal College Mental Health Watch. Thank you very much.
Thank you very much, Asif. So we have about 10 minutes left for our Q&A with all of our speakers. Please feel free to put your questions in the Q&A bit at the bottom of the slides, but there are a few questions that have come in, and maybe we can start off with those. One or all of our speakers will answer them. But I think maybe the first one, probably Subodh could answer, but feel free to chime in, everyone. So one of the questions is, how can trainees get more involved in digital transformation in their trust? I thought we could start there.
So shall I go for that, Faith?
Yes, please.
Shivani, good question, first of all. So I think that's exactly why we've come up with the capability frameworks. As you know, the way it works is that the college sets the standards for training and curricula. So we revise our new curricula. Our curricula, as I've said, are very much about addressing health inequalities, about maximizing your training and your skills so that you can start making a difference to patient outcomes. We need to draw that straight line between your training and your skills, and how good is that in actually addressing the outcomes of your patients that you provide the care for. Now that, I think, who provides that training? The training is provided by schools of psychiatry and local education providers, which is a trust. So my challenge here is to all the DMEs who are responsible for training programs and for heads of school, and they're aware of what we're doing. Well, you need to be thinking about locally that how am I training my future workforce? How are we doing this? So that how are we designing our training programs that actually delivers the training that our trainees need? So I appreciate that just putting in the curriculum, having a piece of paper that says this is the digital literacy framework doesn't translate into action, but that's why conversations like this are important. I think we are presenting this to the heads of school. We're presenting this to all the DMEs network. I've started a whole network with all the DMEs. So hopefully the next year or two, you will see some change coming. I think and if any of you is involved in doing a gap analysis work in saying, well, how does the digital literacy framework compare to what is actually happening on the ground level? What is the gap? And if you want to pilot that in a couple of trusts or a couple of schools, I think we'll be very, very supportive. So Shivani, maybe not a very, clear answer as to what's going to happen, but we can't magically transform these things, and we all have to do our bit. And I hope that you can see that we are in the right path.
Thank you, Subodh. Ross, I think you wanted to contribute to this question as well.
Yeah, I was just thinking to Shivani's original question, and also looking to Shivani, you've also put some more feedback in the text there about the special, anybody with special interest, for all doctors, but thinking briefly about training specifically. I think it's about, I know it sounds daft, but just go and find who your CCIO is, see if you can go and shadow them. If there's not a CCIO in your trust, that's interesting. I'd be surprised, but if not, ask the AMD why there's not a CCIO. I think the next thing is, it doesn't have to just be part of your special interest. I think it's pushing the boundary and saying, what's your EPR, what's your electronic record notes taking system, and say, work out and find out how their change board works. That kind of stuff. It's not just the kind of formal training. It's also thinking about experiential stuff and engaging with that. The people that help to update and change your electronic patient record. Those were my start for 10s. If I had an ST now that asked me that question, that's where I'd be starting. That's where I'd be saying, start with shadowing, start with getting involved in those change boards and get your voice heard. Really
practical advice, Ross. Thank you. Asif, you have.
Yeah, so I was just going to build on what Ross said. As a former CCI, I would have bitten your hand off if you came as a registrar and said, I love digital and how can I help you? Because we're always looking for clinicians to help support us do that kind of transformation work. So I'd be very surprised if your organisation doesn't have a CCIO. So I think that's a really good place to start. There were also lots of other avenues. Obviously, there's the digital SIG, and I'm not saying that that's the only route, but there's something else that you can kind of lend yourself into. There are starting to become a lot of digital fellowships that are available in local areas, and a lot of SVRs put themselves forward for that. And I think that's some really good places to start. And obviously, come and speak to any of us. That's the other place, isn't it? And obviously, you will see on the Royal College website, there's a lot of people in digital SIG that you can just come in and tap into us, and we can try to support you as well.
Thank you, Asif. I thought maybe we've talked about, where we can learn about stuff, but I thought maybe let's talk about something that's topical. There's a couple of comments or questions on AI. So one of them is there an NHS service or independent service using AI-based data guided tools in psychiatry? And the person asking the question says, it's my understanding that there's one known as Precision Psychiatry by Cambridge or Oxford. That's the question. Yes, Asif.
So I don't profess to know a lot about AI, but I know Sussex Partnership Trust are using AI for data mining for part of their pathway. So that's another organisation that I'm aware of. I'm sure increasingly that we'll all move towards that, but that's the only other organisation that I'm aware of. And I think Subodh may have some suggestions as well.
Yeah, I think there are lots of activities happening in this, mostly in the private space. I think, as you mentioned, University of Oxford has got this group that is looking at the Turing Institute, that's looking at AI in mental health care, and they're working with some different providers. I think if the question is that is this happening in the real world for everyone, I don't think, to my knowledge, as yet. I think we've seen examples from the US and here where we're trying to develop that, but I don't think, to my knowledge, there's anything that's happening in the real world. Having said that, lots of apps are using this already, I think, and those apps are being used in the real world by our patients. So that kind of takes my point that, well, why are we as clinicians not involved in those understanding of what is happening with that AI technology? How are the apps, interacting with our patients?
I think it was a question and a contribution on the Q&A, someone who works in conversational AI, who was asking a question about that and interested in hearing feedback on the concept of a conversational AI model for pre-assessment of mental health conditions. So some work, is going on, and I don't know if anyone has a comment on that. We have about a minute.
Well, I think there's a lot of work going on. I think even in, there are people working on actual patient assessments, so that, we don't need any transcriptions. We don't need anyone to dictate a letter afterwards and those tools are available now, so somebody can just analyze the speech that's happening and then generate a letter. And I think I asked ChatGPT to generate a letter for a fictitious OCD patient, and it came up with a very beautiful letter. I think where it lacks, I think, is a person-centered care, a personalized approach, which I think is where we need to be, So I think it will come, I'm sure, but we're not there yet.
Maybe to finish off with one last question on electronic care records. Someone is asking, how can we avoid the pitfalls of making the implementation of digital technologies a cumbersome process that, instead of reducing time and effort, actually does the opposite? So not electronic care records, but how do we avoid making technology an issue rather than an asset?
I'm happy to go first, Faith, and this is one of my big bugbears about how rubbish our EPRs are. So ultimately, I think it's about frontline clinicians getting actively involved in this, because we obviously use these systems on a day-to-day basis, and we know what works and doesn't work, yes? And then we also all have iPhones or, tablets or Galaxies, and we all know that it's actually, they work so much better for us than our EPRs. So that's one thing. I think clinicians actively need to get involved. I think the second thing is then thinking about pathways. And so what I've done where I've worked is we've set out our pathway of what an inpatient pathway would look like, and then develop templates or structured templates to fit that. So that's getting the horse and the cart the right way round, where we fit our systems into what our clinical practice is, rather than we do the other way around, where we have to fit into our computer systems, which absolutely makes no sense at all.
Yeah. And that's perhaps a good point to end, and why this webinar, I think, is so important in terms of introducing everyone to this concept of data and digital literacy, because as clinicians, we should really be leading on some of this work and being there at the very beginning of processes and technology. And so what remains is for me to thank you all for attending this afternoon, and to our three absolutely fantastic speakers for their talks today. I think we all learned a lot about why digital literacy is so important as a critical skill for all of us, and the importance of data and digital literacy standards. And it was good to hear actual examples from Asif about how we can bring data alive to improve patient care, and with the practical examples of how this can be used to inform pathways. And so again, thank you very much for attending today, and a huge thank you to our speakers this afternoon. I hope you have a good day. Thank you very much. Bye.